Counting down. 3, 2, 1. Melody, it's all yours.
Sure. Hello, you're listening to the RxConnect Podcast. This podcast is brought to you by the pharmacy operations at the American Oncology Network. We are committed to delivering operational, clinical, and financial efficiencies based on the most sustainable model, reshaping the future of community oncology practice. I'm your host, Melody Chang, Vice President of Pharmacy Operations at the American Oncology Network. Today is our second episode. We continue to delve into the critical issue of cancer drug shortages, with a specific focus on navigating shortages in GI cancer treatment. To listen to the podcast and to read the transcript, please visit our website at www.aoncology.com. I am delighted to introduce our two outstanding guest speakers, Dr. Mikhail, a medical oncologist at the Zangmeister Cancer Center in Ohio, who has published numerous articles in medical oncology and hematology. He was selected as an editorial board member for the prestigious journal Nature Scientific Reports. In addition, Dr. Mikhail serves as the chairman of AON Quality Committee, overseeing and ensuring the quality of clinical care and the patient safety throughout the organization. My second guest is Brooke Peters, who joined AON in 2021. She serves as the clinical pharmacist for the AON Central Region, covering Arkansas, Indiana, Louisiana, Michigan, Ohio, and Texas. Brooke is a PGY2 trained board-certified oncology pharmacist and was principal investigator on 3 IRB approval studies and created policies and procedures for the improvement for patient care and safety. Welcome, Dr. Mikhail, and welcome, Brooke.
Thank you for having us, Melody.
Thank you, Melody.
We know cancer drugs are a critical component of treatment for many cancer types and play an important role in controlling what can be debilitating symptoms. For well over a decade, the oncology community has experienced shortages of critical drugs that are used to treat a variety of conditions. And the current shortages of anti-cancer drugs are the worst seen in over a decade. A recent survey conducted by NCCN found that 93% of the large cancer centers have experienced a shortage of carboplatin, and 70% of the centers have reported a shortage on cisplatin. So, Dr. Mikhail, as the chairman of AON Quality Committee, you have evaluated and endorsed various shortage mitigation plans for the organization. These plans have ranged from paclitaxel at the end of last year to doxorubicin at the beginning of this year, and the most recent shortages of carboplatin and cisplatin. So can you please enlighten us on the actions taken by the AON Quality Committee to address these situations?
Yes, definitely. Since this is an important issue that we have spent as a group a significant amount of time working on. So as the quality committee, our goal is to ensure that patients receive the highest quality care in spite of any challenges that could occur. And in our case, the biggest challenge was chemotherapy shortage. I'm happy to report that we have followed a multidisciplinary approach that involved many colleagues. I always say it takes a village to treat a patient, and that's part of what we did in our quality a committee where we gathered a group of experienced pharmacists, nurses, physicians, and IT specialists, and went through all the indications of chemotherapy, focusing on the chemotherapies that are in short supply to ensure that we have adequate alternatives that provide patients with the same high quality care. We spent a significant amount of time looking at the various options, and I am happy to report that we were able to put together a plan that we were all very happy with.
Thank you, Dr. Mikhail. Your contributions, thank you. And the QC committee's efforts are greatly appreciated. And thank you for shedding light on the steps being taken to address these pressing issues. And Dr. Mikhail, I know you have a special interest and expertise in the treatment of GI cancer. And then we know both cisplatin and carboplatin are essential for treating a variety of GI cancers, including esophageal, pancreatic, and colorectal cancer. Could you please share your insights into the significant impact of drug shortages, like those of carboplatin and cisplatin, or even 5-FU, on the available treatment options of these patients?
So Melody, this is a very important question, since carboplatin and cisplatin were in short supply, and at the same time, they have many indications and are frequently used in patients with gastrointestinal cancers. So for many gastrointestinal cancers, we were able to substitute carboplatin and cisplatin with a medication in the same group called oxaliplatin. And oxaliplatin has been used in gastrointestinal malignancies. However, if oxaliplatin replaces carboplatin, for example, many times we combine it with 5-FU, or in other situations, we'll combine it with gemcitabine. To give you an example, carboplatin is often combined with paclitaxel and radiation therapy in patients with esophageal and gastroesophageal junction cancers. So we determined that it is reasonable to substitute the carboplatin, paclitaxel, and radiation combination with a combination of 5-FU and oxaliplatin using the FOLFOX regimen. And there is data to support that approach. And alternatively, especially in cancers of the gastrointestinal or the gastroesophageal junction, there is also an approach of using the FOLFOX regimen, or a similar regimen called FLOT, which is a combination of 5-FU, docetaxel, and oxaliplatin, without radiation in the perioperative setting, meaning that patients would receive chemotherapy prior to surgery and then following surgery without using radiation therapy. And there is robust data to justify this approach. Another example is in patients with bile duct cancers, and we treat many patients with those cancers. We determined that based on the available data, that combination of cisplatin and gemcitabine, which is the mainstay of treatment of patients with gastrointestinal cancer, that this combination can be replaced with the combination of oxaliplatin and gemcitabine in the first line setting. And there is emerging data to suggest that this combination can also be combined with other medications such as immune therapy or angiogenesis inhibitors when needed. And the data suggests that this would be an approach that would continue to ensure that patients receive the highest quality care. So these are examples of replacing carboplatin and cisplatin with other agents that are associated with good outcomes and that are not in short supply. Fortunately, 5-FU is not in short supply yet, but we determined that it is very important to be prepared and to start developing a contingency plan in case 5-FU is in short supply. And for intravenous 5-FU, we can replace it with oral capecitabine, which is a very reasonable alternative in the majority of gastrointestinal malignancies, with the exception of maybe dysphagia in patients with kidney dysfunction and patients with who are using feeding tubes. But in case of a shortage situation, we would prioritize intravenous 5-FU for patients who cannot receive the oral capecitabine. And in the rest of the patients, we believe that we can safely use capecitabine as an alternative for 5-FU. And several studies have shown that in certain situations, capecitabine may be even better than 5-FU. So we are confident that in case of a 5-FU shortage, that we would have a contingency plan that again would ensure highest quality care for our patients.
Excellent. Thank you, Dr. Mikhail. Your expertise shines through in your responses. Thank you.
Thank you.
So my next question is for Brooke. Hey, Brooke, as a clinical pharmacist, I know you regularly provide consultations to the providers and nurses and the pharmacy technicians as well. Could you share with our audience the most common inquiries you have received from them during the shortage and describe how you help them navigate the situations?
Thank you, Melody. One of the most common questions that we get from clinics is surrounding patient safety. So they want to be sure that when we're switching from one agent that's on shortage to another, that patient safety is at the forefront and that we've considered everything that we need to and those things that might threaten patient safety. So a couple of important considerations are pre-medications and dosing. So it's important to remember that when we're switching from one agent to another, this is relevant with taxane shortage and also with platinum shortages for GI malignancies. We don't necessarily transition doses in a one-to-one fashion. So when switching from carboplatin or cisplatin to oxaliplatin, that dose might not necessarily be the same. And we really need to take a close look at what doses of those agents have been studied for a particular malignancy and in combination with specific drugs. So it's just really important to keep that in mind. We've had to remind clinical staff of this, and the pharmacists have been instrumental in finding data to support different doses or different treatment regimens. Another consideration, as I mentioned, is pre-medications. So again, with taxanes, pre-medications may be different with paclitaxel versus docetaxel, or again, in the case of our GI malignancies, we need to pay attention to antiemetics. If we're switching a patient from a low dose of carboplatin to a low dose of cisplatin, we may not have needed certain antiemetics that we now do need because we're using a high emetic risk regimen. So it's just important to pay attention to those other components of the treatment plan when we're substituting drugs on shortage. It's not always a simple conversion.
Thank you very much. Thank you, Brooke, for providing this valuable insights. I think that's a very, very useful. I know at some point I heard the pharmacy technicians asking the questions, can we extend the shelf life? Do you have any idea of those shelf life extensions informations where we can obtain the informations, or can we extend the shelf life or not during the shortage?
That's a great question, Melody. So certainly if we had a clinic with, for example, a vial of carboplatin that had just expired a couple of days ago, they would be hard pressed to throw that vial away if we don't have enough to treat all of our patients. So in this situation, data can be found for a lot of drugs, often by reaching out to the manufacturer. So some of this data is published and is available online in medical journals, where maybe an academic institution has done their own study to determine extended stability and shelf life of different drugs. But often manufacturers manufacturers have this data too, and it might just not be reflected on the approved label. So simply reaching out to the manufacturer is a good first step in this situation to see if there's any extended shelf life data. Or, another example, if a drug has been compounded for a patient and that patient can't receive therapy because of aberrant labs, maybe we can keep that bag for a patient later in the day if we determined that that bag has extended stability beyond, again, what's on the approved label. So reaching out to the manufacturers can be very helpful in these kind of scenarios.
Thank you. Thank you so much. Well, thank you, Dr. Mikhail, and thank you, Brooke. Before we wrap up, do you have any closing or final thoughts you would like to share with our audience? I'll start with Dr. Mikhail.
Yes, definitely. I think challenges are going to happen and are sometimes inevitable in our field. But what we've learned is that the most important thing is to approach these challenges in a systematic way that puts the patients in the center of any decision that we make, and that uses all the experience and talents of the available team members, like I mentioned, experienced pharmacists that we have, nurses, and physicians, so that we could tackle the challenges that we're facing. And I'm happy to report that our experience with the drug shortages has proved that our system works in terms of addressing the challenges that we face, and that patient care has not been affected in our network with any of the drug shortages that we are discussing.
Thank you. Thank you, Dr. Mikhail. How about you, Brooke?
Thanks, Melody. I agree with everything that Dr. Mikhail has said. It's definitely a multidisciplinary approach that we find most successful. One thing that's very important with these shortages that we've not discussed is patient education. Patients need to be aware that their drug maybe has changed to a different agent, or that their dose has been adjusted. And it's just very important to keep them always informed. And our frontline staff has been very instrumental in making sure that patients are aware of how and why their treatments have been affected. That's also very important.
Absolutely, absolutely. Thank you. Before we conclude today's podcast, I want to extend our heartfelt thanks to our esteemed speakers for sharing your valuable insights and expertise with us. Your contributions have enriched our discussion, and we are truly grateful for your time and knowledge. And I'd like to thank our audience for listening. This podcast is brought to you by Pharmacy Operations at the American Oncology Network. You can listen to all the podcast recordings on our website at www.aoncology.com. And we hope you enjoyed this episode and looking forward to seeing you at the next one. Thank you. All right. That's the end of our recording. Daryl, how does this sound?
All three of you sound great. So everything came in very well. So thank you, all of you, for, making a really nice, successful podcast here. So I'm just going to do a small little editing thing here, working with marketing, as Melody mentioned earlier. And then that way we'll get this published and it'll be ready for viewing or listening, excuse me.
Great. Sounds great.
Good.
Thanks, Daryl.
Okay. And do we need to, anything we need to redo it? Dr. Mikhail, how you feel about this recording? Anything you want to make a change, or you think we need to retake, or anything you want to add? We can add it.
Not that I can think of. No. From my perspective, I think we're good.
Okay. Thank you very much. And then after Daryl putting things together, before we put it out of, before we push it out, certainly will send the recording to you as well as the script.
Sounds great.
Okay. Thank you. Thank you so much.
Okay.
Thank you.
Bye-bye.
Thanks. Bye.